Okay, thank you, Holman. Thank you, ladies and gentlemen. Yes, I'm going to talk actually really just about vasopressin. My disclosures are shown here. And is there a place for vasopressin? Well, if we look at the Surviving Sepsis campaign, they say there is. They suggest that you could add vasopressin up to 0.03 as a second-line agent. It's a weak recommendation, and they say there's a moderate quality of evidence. Well, I tend to agree with their statement, and I go through in a little bit more detail, a bit more nuanced, how I think we should use vasopressin, what is its place. So I think it should be used as an adjunctive vasopressor, but I do think it's better to use it earlier rather than later. And it's probably too late if we wait until the last-ditch attempt, so not to use it as a rescue therapy. So why do I say that? Well, we've known now for 20 years that there is this relative vasopressin deficiency in septic shock. It was described when taking hypotensive patients for different causes. If you take the cardiogenic shock patients, they have elevated levels, but in septic shock, even though there's the hypotension, they have very normal levels. In fact, the levels maybe peak and then come down again. But they're sort of at the normal level that you might have now sitting in the audience. And therefore, it's described as a relative vasopressin deficiency that people think about giving vasopressin in septic shock. The largest evidence about vasopressin use you'll know from the VAS trial published 10 years ago, nearly, that showed in nearly 800 patients with established septic shock, when vasopressin was added in, there's no evidence that it clearly improved outcome, but I think it suggested that it was at least safe, and I'll show you the safety data later. But it suggested this was potentially a useful second agent that we could add in. But again, you'll be familiar with the one a priori subgroup analysis based around the severity of shock, so whether the patients were on more or less than 15 mics per minute of norepinephrine. That all the benefits seem to be confined to this less severe shock group. Whether this is patients getting earlier, I'll show you some more data on in a minute, but it's certainly the idea of using it in the sicker patients as a rescue therapy, which I think most of us in those days were using it as a rescue therapy, suggests that there's absolutely no difference here at all. So that's why I don't think it should be used as a rescue therapy, but should we use it earlier? Well, this is a post-hoc subgroup analysis, looking at time from eligibility to getting randomized into the trial. There was a 24-hour recruitment window. You also had to have had shock for 6 hours before you were eligible for the trial. And it seems that if there was any benefit, it was the patients who were randomized earlier, maybe earlier in their disease process, if there was any benefit. But maybe it was too late in these patients. Maybe we'd waited too long. So that's why I suggest maybe we should start it earlier. Now, that's trial data. What about real-world data? Well, this has just recently been published. Observational, so it's not randomized, but patients who were either given norepinephrine on its own or combined with vasopressin in the first 4 hours of presenting with their shock. And you see this is time to restoration of blood pressure targets, and you've got a blood pressure target significantly quicker if you were treated with combined norepinephrine and vasopressin. So it seems to make sense. Even if it doesn't improve outcome, you may get your blood pressure target quicker by adding in vasopressin earlier. And again, more real-world data, again, observational, but just trying to identify who was responding best to vasopressin. In this study, they defined responders as your blood pressure increased by 10 millimeters of mercury, or you're able to wean the catecholamines down. And in their multiple logistic regression analysis, the only variable that came out as associated with an improved response was that you were using it as an adjunct vasopressor rather than using it on its own. So it does seem sensible that we started earlier and perhaps in conjunction with the norepinephrine use it together. But at what dose? We had discussions yesterday, and is there a magic dose? Well, we all agree these things are not, that nothing's set in stone as a single target. But there may be patients you might want to start using it even earlier. And I think some of these may be, if you're particularly concerned around tachycardias or arrhythmias. Now, vasopressin works by binding to a whole family of different vasopressin receptors, and it's the V1A receptors on the vascular smooth muscle that cause the vasoconstriction. And there's a whole heap of other effects that you may or may not want, and I'll show some of these in a bit as well. But it's obviously not working through the adrenergic system, but it does put up blood pressure, and again, the evidence, I think, is pretty strong. So this was the first pilot study for the VAS trial, just 24 patients, where they were randomized to get additional norepinephrine or vasopressin just for 4 hours. And you see they were able to wean the norepinephrine off, maintaining the same blood pressure. This was the larger VAS trial, as I said, 800 patients, and you can see clearly once the vasopressin was added in, this is the norepinephrine requirements over time. You can see in the red, the vasopressin group, they come down significantly. And this was the VANISH trial, UK study we published last year in VANISH, using vasopressin early within the first 6 hours. You can see again in the left, blood pressure is identical between the two groups, but able to maintain it with much lower norepinephrine requirements. So it is sparing the catecholamines. And is that a good thing? Maybe. And I think particularly it does seem to be this effect with vasopressin on heart rate. So this is the data from the VAS trial and looking at heart rate over time. And you can see the patients who were given vasopressin, there was a greater reduction in heart rate over time. Whether that's the direct baroreceptor response, and it said that's been talked about with vasopressin receptors, or if it's simply removing some of the beta agonist effect that norepinephrine has, I don't know, but it's certainly been shown in several studies to reduce heart rate. And interestingly, that reduction in heart rate was much more noticeable in the less severe shock group. And that was the patients where we'd seen the benefit as far as survival. And as we talk about the idea of potentially beta blocking patients who have persistent tachycardia and septic shock, one suggestion is, should we actually remove some of the beta agonist effect of norepinephrine if we need to and use vasopressin? So maybe there's some benefit. People ask me, well, is there a concern though you're giving a pure vasoconstrictor with no beta agonist effect? Well, in those patients who had PA catheters in the VAS trial, so this was an older study, remember, about 240 patients, you could see here, looking at contractility, there was no change. It didn't drop when the vasopressin was added in. So it seems reasonably safe to add in to your patients, even if you're concerned about cardiac output. What about any other patients who may benefit? Well, I think it may be helpful to prevent acute renal failure in those patients who are at risk. And particularly if you're again using it earlier, I think it's no good to wait until you've got established acute kidney injury and then add it in. So we talked about vasopressin receptors. I listed them before, and they have these different, the whole family has different responses. And there's some evidence that the V2 receptors may actually bring around some vasodilatation in selective beds, including the pulmonary and brain circulations, for instance. And maybe binding to oxytocin receptors, very similar molecule, similar receptors. Through nitric oxide release, you may get selective vasodilatation in certain organs. And there's particular interest in the kidney around the distribution of these V1A receptors, where there are more on the renal efferent than the afferent arterioles. And then when you cause a vasoconstriction, you may maintain renal perfusion better than if you use norepinephrine, which has an equal distribution of the receptors and may constrict the afferents as well as the efferents. And again, the evidence is pretty consistent across the trials. You see it in a number of studies. So I'll show them again. From the pilot study for VAS, 24 patients, reduced norepinephrine, same blood pressure level, the same blood pressure, but urine output went up over that 4-hour period. Another small study, 23 patients from Canada again using vasopressin early within the first 12 hours. They did use it as a sole agent. So they went up to very high doses of vasopressin here, comparing it to norepinephrine, this time over a 48-hour period, and again, creatinine clearance improved with the vasopressin treatment. In the VAS trial, this is post hoc, but dividing the patients into the rifle criteria at time of randomization. Those who were in the risk groups, their creatinine has risen from 50% from their baseline. There was an improvement in creatinine over time. But if you compare that to the patients who already had established acute kidney failure, there was no difference, again suggesting should you get in earlier. And that was the rationale with the VANISH trial. We tried to use the vasopressin early, and certainly within the first 6 hours was the inclusion criteria. There was no difference in the primary outcome, which was renal failure 3 days. But when we looked at the key secondary outcomes around renal failure, we saw that there was a nearly 10% reduction in the use of renal replacement therapy in the patients treated with vasopressin. Remember, it was a blinded study. The physicians didn't know what they were given. But again, if you look at the duration of filtration once it started, it was the same. Again, it doesn't seem to work once you've already established renal failure, maybe getting in earlier. And again, just to provide the supportive information, it was a secondary outcome, But you look at creatinine over time, again, you'll see in the vasopressin-treated patients here in the blue, it does seem to be lower. So it does seem to be some effect on the kidney. So this may be of benefit. So that's the evidence I was going to show you from septic shock. This is not sepsis, this is cardiac surgery, but a recent trial, and I think is worth adding in just to talk about the drug. So it's a Brazilian study, 300 patients, this time with vasodilatory shock after cardiac surgery. They've used the same doses of vasopressin as we used in the VANISH trial, going up to 0.06 units per minute. And they had a composite endpoint, mortality and a number of postoperative complications. And they found that there was a marked difference in the primary outcome, this composite endpoint, in those patients treated with vasopressin. You see here an odds ratio of 0.55 or 0.52 in the adjusted analysis, highly significant. But of course, it's a composite outcome, so you need to look at the individual components, what was going on in the individual system. And when you look, there was a reduction in acute renal failure. That's where the signal was. So I think, again, as I said, this is not sepsis, but it seems to be consistent. There seems to be an association with treating with vasopressin and improvement in renal function. Importantly, when you look at their secondary outcomes, including safety, and look at the arrhythmias, a significant reduction in AF in this group. Very high rate. I know it's AF, it's cardiac surgery rather than sepsis, but I think quite high rates in both groups, but they were lower again in the vasopressin treated patients. So again, further supportive evidence, I would suggest. But of course, vasopressin has its side effects. All drugs do, and I think it's important that these are considered. So this is the serious adverse event data from VANISH. Overall, they're not dissimilar, but I do point out that there were numerically more cases of digital ischemia in the vasopressin treated patients. We're talking about the microcirculation. Obviously, that is important. Personally, I think more of concern to me is the mesenteric ischemia that I would really worry about, and that's identical in the two groups, identical rates in the same group. What about VAST, which was the other big trial to look at? Well, again, overall, serious adverse events are almost identical between the two groups. It does seem to be relatively safe. The digital ischemia, again, numerically higher in the vasopressin-treated patients. So again, I think it's important we look for the consistency of signals, and it is the same way, so there does seem to be more digital ischemia with vasopressin. But again, I draw you to the mesenteric ischemia, where actually there's not a big difference, but numerically lower in the vasopressin group. So it reassures me that it is safe, but of course we need to consider this adverse event profile when we're prescribing our drugs. So how do I use vasopressin now? I do use it as a second-line vasopressor after I've started the norepinephrine. And if all's going well and the patient's getting better, I leave them alone and they get better. But if that dose is escalating, particularly if it's escalating very quickly, then that's when I add in vasopressin. I think it's better to start it earlier. I don't wait and use it as a rescue therapy. And I tend to use it earlier if I think there's renal dysfunction developing or we've got concerns over arrhythmias and tachycardias. But I do urge caution at high doses. I think that's, I've shown you that evidence. If you have those problems, I think it's always worth going back and reassess, make sure you haven't missed fluid depletion. Do they need further fluid resuscitation? And if we're getting to really high doses and the patient's getting the side effects from all of their vasoconstrictors, actually I would argue, do we need such a high blood pressure target? And evidence maybe actually we could turn down all our vasopressors and accept a lower target, and maybe the patient will actually start improving from there. So that's how I manage it, my vasopressors. And I'll stop there and happy to take questions. Thank you.
Thank you. You almost convinced me.
By the end of the week.
I want to ask you, who uses vasopressin in septic shock patients? How many of you? Not so bad. Yes.
Hi, thank you very much. Very interesting presentation. My name is Felix Lishinsky. I'm from Seattle. Lately in US, at least, vasopressin prices went up, and our hospital, I'm sure many other hospitals, are looking at different ways to decrease our use of vasopressin, and we use it a lot. My question to you is, we have the same approach, of course. Norepinephrine dose goes up, we add vasopressin. On the other side, however, when the patient needs less pressor support, do you have an approach when you stop vasopressin?
Sorry, say just the very last bit again, sorry? I didn't quite catch.
What's your approach to stopping the vasopressin?
To stopping. Personally, I don't think it makes a huge difference. I know there's some data suggesting that if you wean the vasopressin first, there's more hemodynamic instability. In practice, the way the trials have been designed, we left the drug to come off, the blinded study drug, the last one to come off, and we didn't see really any difference between the two. It didn't make a big difference. And in practice, when I'm on, I tend to leave the vasopressin to last, but often if I've handed over to colleagues, they tend to turn off the vasopressin first, and I haven't noticed a big difference. So I don't think it makes too much difference. I think the patient, once they're improving, and as long as you manage that, I don't think it makes a big difference. And as the price, we have the same issue in the UK, the price is going up. My colleagues moan, they blame me for it. I assure you I have nothing to do with that. I just provide the science, but yeah, these are independent reasons why the price of drugs go up, I'm afraid.
Hi, Jan Staszek, Brno, Czech Republic. I have one practical question. If you increase the doses of norepinephrine and you add vasopressin, do you also administer stress dose hydrocortisone? And if you do, if there is any data on doses of vasopressin in this scenario?
So the simple answer is yes, I do add in hydrocortisone. I tend to use the vasopressin first and then go up on the norepinephrine. If we're getting higher doses of norepinephrine, then I add in the steroids. There was the data from the VAST trial that suggested there was an interaction with the steroids. The steroids wasn't controlled. That was why in the VANISH trial, we included a factorial design with the steroids. For the sake of time, I didn't show all the data. We found no interaction with the steroids in that trial. So I think we wait. I know there are more steroid trials coming out. I don't think there's a specific answer with the vasopressin. It makes any difference to managing the steroids and septic shock altogether.